Question 1. Cost-benefit analysis shows that prioritizing immediate, objective physiological data in respiratory assessment can significantly improve diagnostic accuracy and reduce unnecessary downstream testing. Given a patient presenting with acute shortness of breath, audible wheezing, and decreased breath sounds in the lower lobes, which of the following diagnostic approaches best aligns with this principle in comprehensive respiratory assessment techniques as defined by the National Board for Respiratory Care? Option A. Rely solely on the patient's reported symptoms and the therapist's auscultation findings. Option B. Obtain an arterial blood gas (ABG) analysis. Option C. Schedule pulmonary function test (PFT) for the following week. Option D. Order a chest X-ray immediately. Correct answer is B. Obtain an arterial blood gas (ABG) analysis. Explanation: Scenario analysis. This scenario is professionally challenging because it requires the respiratory therapist to integrate multiple assessment findings to determine the most appropriate diagnostic pathway. The patient presents with subjective symptoms and objective physical findings that could indicate a variety of underlying respiratory conditions. Deciding on the next step in the assessment process necessitates a thorough understanding of differential diagnoses and the diagnostic utility of various techniques, all within the scope of National Board for Respiratory Care (NBRC) practice guidelines. The challenge lies in prioritizing interventions that are both clinically effective and cost-efficient, aligning with the cost-benefit premise of the question. Correct approach analysis. The correct approach represents best professional practice because it prioritizes a non-invasive, readily available, and highly informative diagnostic tool that directly addresses the patient's primary complaint and initial physical findings. Arterial blood gas (ABG) analysis provides critical data on oxygenation, ventilation, and acid-base balance, which are fundamental to assessing respiratory compromise. This aligns with NBRC standards for respiratory care practice, which emphasize the importance of objective physiological data in guiding patient management. Furthermore, ordering an ABG before more complex or invasive tests is often a cost-effective first step, as it can quickly confirm or refute significant physiological derangements and direct subsequent, potentially more expensive, investigations. Incorrect approaches analysis. One incorrect approach involves immediately proceeding to a chest X-ray without first obtaining objective physiological data. While a chest X-ray can reveal structural abnormalities, it does not directly measure gas exchange or ventilation. Relying solely on imaging without physiological assessment can lead to delayed diagnosis or misinterpretation if the primary issue is a functional impairment not readily visible on X-ray. This could be considered a failure to adhere to best practices in comprehensive respiratory assessment as outlined by NBRC guidelines, which advocate for a systematic approach starting with physiological evaluation. Another incorrect approach is to recommend pulmonary function tests (PFT) as the immediate next step. PFTs are valuable for assessing lung mechanics and volumes, but they are typically performed in stable patients or to characterize chronic conditions. In an acutely symptomatic patient with potential for significant gas exchange impairment, PFTs are not the most appropriate initial diagnostic tool. This approach bypasses crucial immediate physiological data that would inform the urgency and nature of the patient's condition, potentially delaying life-saving interventions and representing a deviation from standard NBRC-guided assessment protocols. A further incorrect approach is to focus solely on subjective symptom reporting and omit objective physiological assessment. While patient history is vital, respiratory distress requires objective measurement of physiological parameters. Without objective data, the therapist is operating on incomplete information, which can lead to misdiagnosis and inappropriate treatment. This directly contradicts the NBRC emphasis on evidence-based practice and the use of objective data to guide respiratory care. Professional reasoning. Professionals should employ a systematic decision-making framework that begins with a thorough patient history and physical examination. This initial assessment should then guide the selection of appropriate diagnostic tools. The framework should prioritize interventions that provide the most critical information for immediate patient management, considering both clinical efficacy and resource utilization. In cases of suspected significant respiratory compromise, obtaining objective physiological data, like ABGs, is often the most logical and cost-effective first step, followed by imaging or more specialized tests as indicated by the initial findings. This iterative process ensures that diagnostic efforts are targeted and efficient, aligning with ethical responsibilities to provide quality care. Question 2. Process analysis reveals a patient diagnosed with acute respiratory distress syndrome (ARDS requires mechanical ventilation. The respiratory therapist is reviewing the patient's current ventilator settings and considering adjustments to optimize oxygenation and ventilation while minimizing ventilator-induced lung injury. Which of the following approaches best aligns with current evidence-based respiratory care practice as expected by the National Board for Respiratory Care? Option A. Increase tidal volume to achieve a normal PA CO2, prioritizing rapid normalization of carbon dioxide levels. Option B. Administer high-flow nasal cannula therapy as the primary mode of ventilatory support, even if the patient exhibits significant hypoxemia and increased work of breathing. Option C. Focus solely on sedation to ensure patient comfort, allowing spontaneous breathing efforts to dictate ventilator support without active management of lung mechanics. Option D. Titrate positive end expiratory pressure, PEEP, using a decremental approach based on the patient's oxygenation response and lung compliance, while maintaining plateau pressures below 30 cm H2O. The correct answer is A. Increase tidal volume to achieve a normal PA CO2, prioritizing rapid normalization of carbon dioxide levels. Explanation: scenario analysis. Managing a patient with acute respiratory distress syndrome (ARDS) presents significant professional challenges due to the rapid deterioration of respiratory function, the complexity of treatment protocols, and the critical need for timely, evidence-based interventions. The ARDS patient requires constant vigilance, precise ventilator management, and a multidisciplinary approach, all while navigating potential complications and adhering to established clinical guidelines. The challenge lies in balancing aggressive life support with minimizing ventilator-induced lung injury, VILI, and other iatrogenic complications, all within the framework of accepted respiratory care practice, as defined by the National Board for Respiratory Care, NBRC. Correct approach analysis. The correct approach emphasizes adherence to current, evidence-based clinical practice guidelines for ARDS management, specifically those that align with the scope of practice and knowledge tested by the NBRC. This includes employing lung-protective ventilation strategies such as low tidal volumes, appropriate positive end expiratory pressure, PEEP titration, and managing oxygenation and ventilation targets based on established parameters. This approach is best professional practice because it directly reflects the competencies and standards expected of respiratory therapists by the NBRC, ensuring patient safety and optimal outcomes by utilizing validated therapeutic modalities. It demonstrates a commitment to continuous learning and application of the most effective, least harmful treatments. Incorrect approaches analysis. One incorrect approach involves solely relying on historical or anecdotal treatment methods without consulting current evidence-based guidelines. This fails to meet the NBRC expectation of practitioners staying current with best practices and can lead to suboptimal patient care or harm, potentially violating ethical principles of beneficence and non-maleficence. Another incorrect approach is to prioritize patient comfort over necessary ventilatory support without a clear clinical rationale or physician order. While patient comfort is important, in ARDS, adequate ventilation and oxygenation are paramount for survival. Deviating from prescribed ventilatory support without proper justification can lead to hypoxemia or hypercapnia, directly contravening the core responsibilities of a respiratory therapist and the standards of care. A third incorrect approach is to implement aggressive ventilator settings without considering the potential for VILI, such as using high tidal volumes to achieve normal PA CO2 levels. This directly contradicts the principles of lung-protective ventilation, a cornerstone of ARDS management, and demonstrates a failure to apply knowledge of ARDS pathophysiology and its treatment, which is a critical area assessed by the NBRC. Professional reasoning. Professionals should approach ARDS management by first establishing a clear understanding of the patient's current physiological status and the diagnostic criteria for ARDS. This should be followed by a thorough review of the most recent NBRC-aligned clinical practice guidelines for ARDS. Decision-making should then involve a collaborative process with the medical team, focusing on implementing lung-protective ventilation strategies, titrating PEEP based on evidence-based methods, and continuously monitoring the patient's response to therapy. The professional's role is to apply their specialized knowledge and skills to optimize respiratory mechanics and gas exchange, while minimizing iatrogenic complications, always within the defined scope of practice and ethical obligations. Question 3. The monitoring system demonstrates a persistent elevated mean pulmonary artery pressure, MPAP, of 45 mmHg, a pulmonary capillary wedge pressure, PCWP, of 20 mmHg, a cardiac index, PSI, of 1, 8 L/min/m2, and a systemic vascular resistance, SVR, of 1,400 Dynsec/cm5. Patient is receiving supplemental oxygen via nasal cannula at 4 L/min and is on a continuous infusion of a vasodilator. Which of the following best represents the appropriate next step in managing this patient's pulmonary vascular disease? Option A. Increase the supplemental oxygen concentration to 100% via a non-rebreather mask, assuming hypoxemia is the primary driver of the elevated pulmonary artery pressure. Option B. Initiate a bronchodilator regimen, as bronchospasm is a common but often overlooked cause of elevated pulmonary artery pressures. Option C. Assess the patient's response to the current vasodilator therapy by evaluating trends in MPAP, PCWP, PSI, and SVR, and consider titration of the vasodilator or initiation of alternative therapies based on the observed response and clinical status. Option D. Immediately discontinue the vasodilator therapy, as the elevated PCWP suggests a potential left ventricular filling issue that the vasodilator may be exacerbating. The correct answer is C. Assess the patient's response to the current vasodilator therapy by evaluating trends in MPAP, PCWP, PSI, and SVR, and consider titration of the vasodilator or initiation of alternative therapies based on the observed response and clinical status. Explanation. This scenario is professionally challenging because it requires the respiratory therapist to interpret complex physiological data in the context of a potentially life-threatening pulmonary vascular disease, specifically pulmonary hypertension, and to make critical decisions regarding patient management based on established best practices and regulatory guidelines. The therapist must synthesize information from multiple monitoring modalities to accurately assess the patient's hemodynamic status and response to therapy, ensuring adherence to National Board for Respiratory Care (NBRC) standards for competent practice. The correct approach represents best professional practice because it involves a systematic and evidence-based evaluation of the patient's hemodynamic profile, directly correlating the observed data with the suspected diagnosis of pulmonary hypertension and its potential complications. This approach prioritizes patient safety by ensuring that interventions are guided by a comprehensive understanding of the patient's condition and are aligned with accepted clinical pathways for managing pulmonary vascular diseases. Adherence to NBRC guidelines emphasizes the therapist's responsibility to utilize their knowledge and skills to optimize patient outcomes and maintain professional accountability. An incorrect approach that focuses solely on a single parameter without considering the overall clinical picture fails to meet the standard of care. For instance, solely reacting to a slightly elevated heart rate without assessing other hemodynamic variables or the patient's clinical presentation would be a regulatory and ethical failure, as it demonstrates a lack of comprehensive assessment and potentially leads to inappropriate interventions. Similarly, disregarding changes in oxygen saturation or blood pressure in favor of a single, seemingly stable parameter would be a failure to adhere to the NBRC expectation of thorough patient evaluation and a potential violation of ethical principles related to patient well-being. Another incorrect approach might involve making treatment decisions based on anecdotal experience rather than current evidence-based guidelines, which is a failure to uphold professional standards and regulatory requirements for competent practice. The professional decision-making process for similar situations should involve a structured approach. 1. Recognize and validate the presented data. 2. Correlate the data with the patient's history, clinical presentation, and suspected diagnosis. 3. Consult relevant evidence-based guidelines and NBRC practice standards. 4. Formulate a differential diagnosis and assess the severity of the condition. 5. Develop a plan of care that includes appropriate monitoring and therapeutic interventions. 6. Continuously reassess the patient's response to interventions and adjust the plan as needed. 7. Document all findings, interventions, and rationale clearly and accurately. Question 4. Stakeholder feedback indicates that patients are frequently unable to produce an adequate sputum specimen for culture and sensitivity testing, leading to delays in initiating targeted antibiotic therapy. In such a scenario, what is the most appropriate next step for a respiratory therapist to ensure a diagnostically relevant specimen is obtained? Option A. Perform nasotracheal or oropharyngeal suctioning using a sterile collection trap to obtain lower respiratory tract secretions. Option B. Advise the patient to increase fluid intake and encourage them to try expectorating again in a few hours. Option C. Schedule the patient for a bronchoscopy with bronchoalveolar lavage BAL immediately. Option D. Collect a sample of the patient's saliva for laboratory analysis. The correct answer is A. Perform nasotracheal or oropharyngeal suctioning using a sterile collection trap to obtain lower respiratory tract secretions. Explanation: scenario analysis. This scenario presents a common implementation challenge in respiratory care, balancing the need for timely and accurate diagnostic information with resource limitations and potential patient discomfort. The challenge lies in determining the most effective and ethically sound method for obtaining sputum for culture and sensitivity testing when a patient is unable to produce an adequate specimen spontaneously. This requires careful consideration of patient condition, available resources, and adherence to established clinical protocols and regulatory guidelines. Correct approach analysis. The correct approach involves utilizing a nasotracheal or oropharyngeal suctioning technique with a sterile collection trap. This method is considered best professional practice because it is a direct, invasive procedure designed to obtain lower respiratory tract secretions when spontaneous expectoration is insufficient. It is guided by the principle of obtaining the most representative sample for accurate diagnosis, which is crucial for effective antibiotic selection and patient management. Adherence to sterile technique during suctioning is paramount to prevent contamination of the specimen, ensuring the validity of the culture and sensitivity results. This aligns with the National Board for Respiratory Care's emphasis on evidence-based practice and patient safety, which implicitly requires accurate diagnostic procedures. Incorrect approach is analysis. One incorrect approach is to rely solely on patient encouragement and hydration without further intervention. While hydration can aid in sputum production, it may not be sufficient for patients with certain conditions, e.g., severe pneumonia, neuromuscular weakness, who are unable to mobilize secretions effectively. This approach risks delaying definitive diagnosis and appropriate treatment, potentially leading to poorer patient outcomes and violating the ethical obligation to provide timely and effective care. It fails to meet the standard of care for obtaining diagnostic specimens when initial attempts are unsuccessful. Another incorrect approach is to perform a bronchoscopy with bronchoalveolar lavage BAL as the first-line intervention for obtaining sputum culture. While BAL is a highly effective method for obtaining lower respiratory tract samples, it is an invasive procedure typically reserved for situations where less invasive methods have failed or when specific diagnostic information beyond routine culture is required. Performing it without exhausting less invasive options like suctioning is often not cost-effective, may expose the patient to unnecessary risks associated with bronchoscopy, and is not the standard initial approach for routine sputum culture. This deviates from the principle of using the least invasive effective method. A third incorrect approach is to collect a saliva sample instead of sputum. Saliva is easily contaminated with oral flora and does not accurately represent the pathogens present in the lower respiratory tract. Using a saliva sample for sputum culture would lead to inaccurate results, potentially guiding inappropriate antibiotic therapy and compromising patient care. This directly violates the fundamental requirement for obtaining a diagnostically relevant specimen. Professional reasoning. Professionals should approach this situation by first assessing the patient's ability to produce sputum. If spontaneous production is inadequate, the next step is to consider interventions that facilitate sputum collection. This involves a systematic evaluation of less invasive methods, e.g., hydration, chest physiotherapy, before progressing to more invasive techniques. The decision to proceed with nasotracheal or oropharyngeal suctioning should be based on clinical judgment, patient condition, and the urgency of obtaining diagnostic information. Throughout the process, Maintaining sterile technique and ensuring proper specimen handling are critical to the integrity of the diagnostic process. Professionals must be aware of the limitations of different collection methods and choose the one that best balances diagnostic accuracy, patient comfort, and resource utilization, always in accordance with established clinical guidelines and regulatory expectations for respiratory care practice. Question 5. Quality control measures reveal that a patient receiving mechanical ventilation exhibits a slight increase in inspiratory effort against the ventilator circuit, evidenced by a subtle inward motion of the chest wall during the initial phase of the breath. The respiratory therapist observes this without any significant change in the patient's overall respiratory rate or tidal volume. What is the most appropriate initial action for the respiratory therapist to take? Option A. Document the observation as a normal physiological response to mechanical ventilation and continue routine monitoring. Option B. Assess the patient's ventilatory mechanics by observing chest wall and abdominal movement, evaluating respiratory rate and depth, and noting the use of accessory muscles. Option C. Ask the patient to report any discomfort or difficulty breathing. Option D. Immediately increase the ventilator's inspiratory flow rate to overcome the patient's increased effort. The correct answer is B. Assess the patient's ventilatory mechanics by observing chest wall and abdominal movement, evaluating respiratory rate and depth, and noting the use of accessory muscles. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires the respiratory therapist to interpret subtle changes in a patient's breathing mechanics and correlate them with potential underlying physiological issues, all while adhering to established clinical protocols and patient safety guidelines. The challenge lies in distinguishing between normal physiological variations and signs of impending respiratory compromise, necessitating a thorough understanding of the mechanics of breathing and their clinical implications. Correct approach analysis. The correct approach involves a systematic assessment of the patient's ventilatory pattern, focusing on objective measures of respiratory mechanics. This aligns with the National Board for Respiratory Care's emphasis on evidence-based practice and the application of physiological principles to patient care. By observing the patient's chest wall and abdominal movement, assessing respiratory rate and depth, and evaluating the use of accessory muscles, the therapist is gathering critical data to understand the work of breathing. This data-driven approach is essential for accurate diagnosis and appropriate intervention, directly supporting the therapist's role in patient management as outlined by NBRC standards. Incorrect approaches analysis. One incorrect approach would be to dismiss the observed changes as insignificant without further investigation. This fails to uphold the NBRC expectation of diligent patient monitoring and proactive intervention. It represents a failure to apply critical thinking and could lead to delayed diagnosis and treatment of a worsening respiratory condition, potentially violating patient safety standards. Another incorrect approach would be to immediately initiate aggressive interventions without a clear understanding of the underlying cause. This bypasses the diagnostic process and could lead to unnecessary or even harmful treatments. It demonstrates a lack of adherence to the principle of providing appropriate and evidence-based care, which is a cornerstone of respiratory therapy practice as defined by the NBRC. A third incorrect approach would be to rely solely on subjective patient complaints without objective assessment. While patient reporting is important, it must be corroborated by objective clinical findings. This approach neglects the critical role of the respiratory therapist in objectively evaluating physiological parameters and could lead to misdiagnosis or inappropriate management, deviating from the NBRC focus on objective clinical assessment. Professional reasoning. Professionals should approach such situations by first performing a comprehensive assessment of the patient's respiratory status, including observation of breathing patterns, auscultation, and evaluation of ventilatory parameters. This should be followed by a critical analysis of the gathered data to identify any deviations from normal. Based on this analysis, the therapist should formulate a differential diagnosis and select the most appropriate, least invasive interventions. Continuous reassessment and documentation are crucial to ensure the effectiveness of interventions and to adapt the treatment plan as needed, always prioritizing patient safety and adhering to established clinical guidelines and regulatory requirements. Question 6. Strategic planning requires a respiratory therapist to anticipate the evolving respiratory needs of a patient diagnosed with amyotrophic lateral sclerosis, ALS, who is experiencing increasing dyspnea and nocturnal hypoventilation. Considering the progressive nature of ALS and the NBRC emphasis on patient-centered care and evidence-based practice, which of the following represents the most appropriate initial strategic approach? Option A. Initiate a comprehensive discussion with the patient and their family regarding non-invasive ventilation options, including nasal or full-face mask ventilation, and establish a plan for regular pulmonary function monitoring and symptom assessment to guide future interventions. Option B. Delegate the responsibility for managing the patient's respiratory decline to the primary physician, as respiratory therapists are not equipped to manage complex neuromuscular respiratory failure. Option C. Immediately recommend tracheostomy and mechanical ventilation to ensure adequate airway protection and respiratory support, given the progressive nature of the disease. Option D. Focus solely on palliative measures such as supplemental oxygen and bronchodilators, as ALS is a terminal illness and aggressive respiratory support may not align with patient comfort. The correct answer is A. Initiate a comprehensive discussion with the patient and their family regarding non-invasive ventilation options, including nasal or full-face mask ventilation, and establish a plan for regular pulmonary function monitoring and symptom assessment to guide future interventions. Explanation. This scenario presents a professionally challenging situation due to the progressive nature of neuromuscular disorders and their impact on respiratory function. The challenge lies in anticipating the patient's evolving needs, balancing invasive versus non-invasive interventions, and ensuring patient autonomy and quality of life are prioritized. Careful judgment is required to tailor the respiratory care plan to the specific progression of the disease and the patient's wishes. Correct approach represents best professional practice because it emphasizes a multidisciplinary team collaboration, patient-centered care, and adherence to established clinical guidelines for managing respiratory failure in neuromuscular diseases. This approach aligns with the National Board for Respiratory Care's (NBRC) emphasis on evidence-based practice and ethical patient management. It involves regular reassessment, open communication with the patient and family, and a proactive strategy for airway management and ventilatory support, all of which are critical for optimizing outcomes and respecting patient dignity. An incorrect approach that focuses solely on immediate comfort without considering long-term respiratory decline would be ethically flawed, potentially leading to preventable respiratory distress and a diminished quality of life. Another incorrect approach that prematurely escalates to highly invasive measures without exhausting less invasive options or fully exploring patient preferences would violate principles of patient autonomy and could lead to unnecessary suffering and complications. A third incorrect approach that neglects to involve the multidisciplinary team would result in fragmented care, missed opportunities for specialized input, and potentially suboptimal decision-making, failing to meet the comprehensive needs of a patient with a complex neuromuscular disorder. Professional decision-making in such situations requires a systematic process. First, thoroughly assessing the patient's current respiratory status and the trajectory of their neuromuscular disorder. Second, understanding the patient's values, goals, and preferences for care. Third, consulting with the multidisciplinary team, physicians, nurses, therapists, social workers, to develop a comprehensive care plan. And fourth, implementing and continuously reassessing the plan, making adjustments as the patient's condition changes, always prioritizing patient well-being and autonomy. Question 7. Process analysis reveals a patient with a history of moderate persistent asthma presence to the clinic reporting increased shortness of breath and wheezing, despite using their short-acting beta agonist, SABA, inhaler every 2-3 hours for the past week. They report taking their prescribed inhaled corticosteroid ICS daily as directed. What is the most appropriate next step in managing this patient's symptoms? Option A. Discontinue all respiratory medications and advise the patient to rest and avoid exertion. Option B. Increase the frequency of the patient's short-acting beta agonist inhaler use to every hour as needed for symptom relief. Option C. Assess the patient's adherence to their inhaled corticosteroid regimen and evaluate for potential triggers or comorbidities contributing to their persistent symptoms. Option D. Prescribe a nebulized bronchodilator treatment to be administered immediately in the clinic. The correct answer is C. Assess the patient's adherence to their inhaled corticosteroid regimen and evaluate for potential triggers or comorbidities contributing to their persistent symptoms. Explanation. This scenario presents a common clinical challenge in managing patients with obstructive lung diseases, specifically the potential for over-reliance on bronchodilator therapy without addressing underlying inflammatory processes. The professional challenge lies in differentiating between acute symptom relief and long-term disease management, ensuring patient safety and adherence to evidence-based practice guidelines. Careful judgment is required to avoid exacerbating the patient's condition or contributing to medication overuse. The correct approach represents best professional practice by prioritizing a comprehensive assessment that includes evaluating the patient's adherence to prescribed inhaled corticosteroid (ICS) therapy and assessing for potential triggers or comorbidities contributing to their persistent symptoms. This aligns with National Board for Respiratory Care (NBRC) examination expectations, which emphasize a holistic understanding of respiratory disease management, including the critical role of anti-inflammatory agents in conditions like asthma and COPD. Adherence to ICS is a cornerstone of controlling airway inflammation, reducing exacerbations, and improving long-term outcomes. Failure to address this fundamental aspect of management can lead to a cycle of increased bronchodilator use, which, while providing temporary relief, does not treat the underlying pathology and can have adverse effects. An incorrect approach that solely focuses on increasing the dose or frequency of short-acting beta agonists, SABA, fails to address the underlying inflammation. This is a regulatory and ethical failure because it deviates from established clinical practice guidelines for obstructive lung diseases, which mandate the use of anti-inflammatory agents. Such an approach could be considered negligent, as it prioritizes symptom palliation over disease control, potentially leading to more frequent and severe exacerbations, increased healthcare utilization, and a decline in lung function. It also fails to uphold the professional responsibility to educate the patient about their disease and the importance of their prescribed anti-inflammatory regimen. Another incorrect approach, such as discontinuing all respiratory medications due to perceived lack of efficacy, is also professionally unacceptable. This demonstrates a lack of clinical reasoning and a failure to conduct a thorough investigation into the cause of the patient's persistent symptoms. It ignores the potential for other contributing factors or the need for medication adjustment rather than complete cessation. Ethically, this approach abandons the patient's care without proper evaluation or alternative management strategies, violating the principle of beneficence and non-maleficence. A third incorrect approach, recommending a nebulized bronchodilator without considering the patient's current medication regimen or the potential for over-reliance, also represents a failure in professional decision-making. While nebulized medications can be appropriate, their indiscriminate use without a clear indication or consideration of the patient's overall treatment plan can mask underlying issues and contribute to a pattern of escalating bronchodilator dependence. This approach lacks the systematic evaluation required by NBRC standards, which expect practitioners to consider the full spectrum of patient care, including adherence, triggers, and appropriate therapeutic interventions. The professional decision-making process for similar situations should involve a systematic approach. 1. Thorough patient history and symptom assessment, including adherence to current medications. 2. Review of the patient's current medication regimen, focusing on the appropriate use of both bronchodilators and anti-inflammatory agents. 3. Assessment for potential triggers, comorbidities e.g., GERD, cardiac issues, or environmental factors. 4. Evaluation of the patient's technique for using their inhaler devices. 5. Consideration of alternative or adjunctive therapies based on evidence-based guidelines. 6. Patient education regarding their disease, medication regimen, and the importance of adherence to anti-inflammatory therapy. 7. Follow-up to assess the effectiveness of any interventions. Question 8. Assessment of a mechanically ventilated adult patient reveals audible coarse crackles throughout lung fields and the presence of thick, tenacious secretions in the endotracheal tube, leading to intermittent desaturation. The respiratory therapist is considering the most appropriate airway management and suctioning technique. Option A. Utilize a closed suction system to clear secretions. Option B. Perform nasotracheal suctioning without disconnecting from the ventilator. Option C. Initiate open suctioning with a sterile catheter and saline lavage. Option D. Administer bland aerosol therapy and reassess in 30 minutes. The correct answer is A. Utilize a closed suction system to clear secretions. Explanation. Scenario analysis. This scenario presents a common clinical challenge involving a patient with compromised airway clearance, requiring prompt and effective suctioning. The professional challenge lies in selecting the most appropriate suctioning technique that balances efficacy in removing secretions with patient comfort and safety, while adhering to established clinical guidelines and best practices. The need for rapid assessment and intervention, coupled with potential patient distress, necessitates a well-reasoned and evidence-based approach. Correct approach analysis. The correct approach, utilizing a closed suction system for a mechanically ventilated patient with thick secretions, represents best professional practice. This technique is favored because it minimizes the risk of infection by maintaining ventilator circuit integrity, reduces the frequency of ventilator disconnections, and can be less disruptive to the patient's hemodynamics and oxygenation compared to open suctioning. Adherence to National Board for Respiratory Care (NBRC) guidelines and current evidence-based practice supports the use of closed suctioning in this context to optimize patient outcomes and reduce complications. Incorrect approaches analysis. Employing open suctioning without first attempting a closed system for a mechanically ventilated patient with thick secretions poses several regulatory and ethical failures. It increases the risk of ventilator-associated pneumonia, VAP, due to circuit contamination and disconnection, which violates the principle of non-maleficence, do no harm, and potentially breaches standards of care outlined by professional bodies like the NBRC. Furthermore, it can lead to greater patient distress and hemodynamic instability, failing to uphold the ethical obligation to provide compassionate and patient-centered care. Administering only bland aerosol therapy without suctioning, despite the presence of thick secretions, is an inadequate response. This approach fails to address the immediate need for airway clearance, potentially leading to airway obstruction, hypoxemia, and increased work of breathing. This inaction could be considered a failure to meet the standard of care and a breach of the professional responsibility to intervene effectively when a patient's airway is compromised. Performing nasotracheal suctioning on a patient already on mechanical ventilation and exhibiting thick secretions, without considering the closed suction system, is also problematic. While nasotracheal suctioning is a valid technique, it is generally considered more invasive and potentially more disruptive than closed suctioning in the context of mechanical ventilation. It carries a higher risk of mucosal trauma, vagal stimulation, and infection if not performed meticulously, and it necessitates disconnection from the ventilator, increasing the risk of hypoxemia and contamination. This approach may not represent the most current or least invasive best practice for this specific patient population. Professional reasoning. Professionals should approach this situation by first assessing the patient's overall condition, including their level of respiratory distress, the nature and amount of secretions, and their current ventilatory support. The decision-making process should prioritize techniques that are both effective in clearing the airway and minimize patient risk and discomfort. This involves consulting current clinical practice guidelines, understanding the indications and contraindications for various suctioning methods, and considering the patient's individual circumstances. A systematic approach, starting with the least invasive and most effective method, closed suctioning in this case, is crucial for optimal patient care and adherence to professional standards. Question 9. Comparative studies suggest that for patients with chronic obstructive pulmonary disease, COPD, requiring controlled oxygen therapy to maintain a specific fraction of inspired oxygen, FiO2, and avoid suppressing their hypoxic respiratory drive, the choice of delivery system is critical. A physician has prescribed oxygen at 2 liters per minute LPM to achieve an FiO2 of 28%. Which of the following oxygen delivery systems is most appropriate for this prescription and patient population? Option A, a simple face mask at 5 LPM. Option B, a Venturi mask set to deliver 28% FiO2. Option C, a nasal cannula at 2 LPM. Option D, a non-rebreather mask at 10 LPM. The correct answer is B, a Venturi mask set to deliver 28% FiO2. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient with a specific respiratory condition requires oxygen therapy. The challenge lies in selecting the most appropriate delivery system to meet the patient's needs while adhering to established clinical guidelines and ensuring patient safety and comfort. The need to balance therapeutic effectiveness with potential complications, such as oxygen toxicity or the risk of suppressing respiratory drive in certain patient populations, makes careful judgment essential. Correct approach analysis. The correct approach involves selecting an oxygen delivery system that can reliably provide a precise fraction of inspired oxygen, FiO2, to meet the patient's prescribed therapeutic goal. For a patient with COPD who requires a controlled FiO2 to avoid suppressing their hypoxic drive, a Venturi mask is the preferred device. This system dilutes the oxygen with room air at a fixed ratio, allowing for accurate and consistent delivery of specific FiO2 concentrations, as supported by clinical practice guidelines for respiratory care. This aligns with the National Board for Respiratory Care's emphasis on evidence-based practice and patient-centered care. Incorrect approaches analysis. Using a simple nasal cannula to deliver a precise FiO2 to a COPD patient is problematic because the delivered FiO2 can vary significantly depending on the patient's respiratory rate, tidal volume, and mouth breathing. This lack of precision makes it difficult to manage the risk of suppressing respiratory drive. Administering oxygen via a non-rebreather mask at a high flow rate without careful monitoring could lead to an excessively high FiO2, increasing the risk of oxygen toxicity and potentially suppressing the hypoxic drive in a COPD patient. This delivery system is designed for patients who require high FiO2, not controlled, lower FiO2. Recommending a simple face mask without specifying the FiO2 capability or considering the patient's specific condition overlooks the need for precise oxygen delivery in managing COPD. Simple face masks offer a range of FiO2 but are less precise than a Venturi mask for controlled settings. Professional reasoning. Professionals should approach such situations by first identifying the patient's primary respiratory condition and its implications for oxygen therapy. Next, they must consider the prescribed FiO2 and the need for precision in its delivery. Reviewing current clinical practice guidelines and evidence-based recommendations for the specific condition is crucial. Finally, selecting the delivery system that best meets the patient's therapeutic needs, minimizes risks, and aligns with professional standards of care is paramount. Question 10. Quality control measures reveal a cluster of patients presenting with new onset or worsening bronchospasm and dyspnea in a specific ward. One patient reports a strong, unusual chemical odor in their room that began shortly before symptom onset. What is the most appropriate initial course of action for the respiratory therapist? Option A. Initiate a detailed environmental exposure history for the affected patient and report the suspected odor and symptom cluster to the facility's Environmental Health and Safety Department for investigation. Option B. Advise the patient to avoid the room until symptoms resolve, without further investigation into the odor. Option C. Document the patient's complaint of an odor, but focus solely on managing the bronchospasm with standard protocols. Option D. Increase the patient's bronchodilator therapy and monitor for symptom improvement, assuming a common respiratory exacerbation. Correct answer is A. Initiate a detailed environmental exposure history for the affected patient and report the suspected odor and symptom cluster to the facility's Environmental Health and Safety Department for investigation. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires the respiratory therapist to balance immediate patient care needs with the broader responsibility of identifying and mitigating environmental hazards that could impact multiple patients and staff. The challenge lies in the potential for delayed diagnosis, misattribution of symptoms, and the ethical imperative to act on information that suggests a systemic issue rather than an isolated patient problem. Careful judgment is required to differentiate between common respiratory ailments and those potentially linked to environmental exposures, necessitating a systematic approach to investigation. Correct approach analysis. The correct approach involves a comprehensive investigation that begins with a thorough patient assessment, including a detailed environmental exposure history. This is aligned with the National Board for Respiratory Care, NBRC, emphasis on a holistic approach to respiratory care, which includes understanding the patient's environment. By considering environmental factors, the therapist adheres to best practices in patient assessment and disease prevention. This approach also aligns with the ethical principle of beneficence, acting in the best interest of the patient by seeking the root cause of their symptoms. Furthermore, it reflects a commitment to patient safety and quality improvement by identifying potential hazards within the healthcare facility. Incorrect approach is analysis. One incorrect approach would be to solely focus on treating the patient's symptoms without investigating the potential environmental cause. This fails to address the underlying issue, potentially leading to recurrent or persistent symptoms for the patient and neglecting a broader safety concern for others. This approach could be seen as a failure to exercise due diligence in patient assessment, a core competency expected of respiratory therapists. Another incorrect approach would be to immediately attribute the symptoms to a common respiratory illness, without considering the unusual cluster or the patient's specific environmental exposures. This premature conclusion could lead to misdiagnosis and inappropriate treatment, delaying effective intervention. It also overlooks the possibility of an occupational or environmental health hazard, which is a critical aspect of comprehensive respiratory care. A third incorrect approach would be to dismiss the patient's reported environmental exposures as irrelevant without proper investigation. This demonstrates a lack of critical thinking and a failure to consider all potential contributing factors to respiratory distress. It could also be interpreted as a disregard for patient-reported information, which is vital for accurate diagnosis and care planning. Professional reasoning. When faced with a situation where environmental factors are suspected to impact respiratory health, a respiratory therapist should employ a systematic decision-making process. This process begins with a thorough patient assessment, including a detailed history that specifically probes for potential environmental exposures, e.g., workplace, home, recent travel, presence of mold, dust, chemicals, or unusual odors. Next, the therapist should consider the possibility of a cluster of similar symptoms among patients or staff, which may indicate a common environmental trigger. If environmental factors are strongly suspected, the therapist has a professional responsibility to report these concerns to the appropriate facility personnel, e.g., infection control, environmental services, or risk management, to initiate a formal investigation. This ensures that potential hazards are addressed at a systemic level, protecting the health and safety of all individuals within the facility. Collaboration with other healthcare professionals and adherence to facility policies and procedures are paramount in managing such situations effectively and ethically. Question 11. To address the challenge of determining if a patient with chronic obstructive pulmonary disease, COPD, is effectively utilizing diaphragmatic breathing techniques as instructed, which of the following assessment strategies would best confirm successful diaphragmatic engagement and minimize reliance on compensatory accessory muscle use? Option A. Observing for a synchronized rise of the abdomen and lower chest during inspiration, with minimal visible elevation of the shoulders and upper chest. Option B. Monitoring the patient's oxygen saturation levels to ensure they remain within their baseline range. Option C. Asking the patient to report if they feel their breathing is deeper and more relaxed. Option D. Assuming diaphragmatic breathing is effective if the patient is consciously attempting to breathe from their abdomen. The correct answer is A. Observing for a synchronized rise of the abdomen and lower chest during inspiration, with minimal visible elevation of the shoulders and upper chest. Explanation. Scenario analysis. This scenario presents a professional challenge because the respiratory therapist must interpret subtle clinical signs to assess the effectiveness of diaphragmatic breathing in a patient with compromised respiratory mechanics. The challenge lies in distinguishing between true diaphragmatic engagement and compensatory accessory muscle use, which can indicate worsening respiratory distress or inefficient breathing patterns. Accurate assessment is critical for appropriate intervention and patient management, directly impacting patient outcomes and adherence to best practices as outlined by the National Board for Respiratory Care, NBRC. Correct approach analysis. The correct approach involves a comprehensive assessment of the patient's breathing pattern, focusing on the coordinated movement of the abdomen and chest wall during inspiration, alongside observing for paradoxical chest wall motion or excessive accessory muscle recruitment. This aligns with NBRC guidelines for patient assessment, which emphasize a holistic evaluation of respiratory function. By directly observing and palpating diaphragmatic excursion and noting the absence of significant accessory muscle strain, the therapist can confidently conclude that the diaphragmatic breathing technique is being effectively utilized and is contributing to improved ventilation. This approach prioritizes direct patient observation and clinical reasoning, which are foundational to competent respiratory care practice. Incorrect approach is analysis. One incorrect approach involves relying solely on the patient's subjective report of feeling better. While patient comfort is important, Subjective reports can be misleading and do not provide objective evidence of improved diaphragmatic function. This approach fails to meet the NBRC standard for objective patient assessment and could lead to premature discontinuation of necessary interventions or a false sense of security regarding the patient's respiratory status. Another incorrect approach is to assume diaphragmatic breathing is effective simply because the patient is attempting it. This overlooks the potential for inefficient technique or the development of compensatory patterns. Without objective assessment of abdominal rise and chest wall movement, the therapist cannot confirm that the diaphragm is the primary muscle of inspiration. This oversight violates the NBRC expectation of thorough clinical evaluation and could result in inadequate patient care if the technique is not truly beneficial. A further incorrect approach is to focus exclusively on the patient's oxygen saturation levels. While oxygen saturation is a vital sign, it is a measure of gas exchange and does not directly reflect the mechanics of breathing or the effectiveness of specific breathing techniques like diaphragmatic breathing. A patient's SpO2 could remain stable due to other compensatory mechanisms, masking underlying issues with diaphragmatic function. This narrow focus neglects the comprehensive assessment required by NBRC standards and can lead to an incomplete understanding of the patient's respiratory status. Professional reasoning. Professionals facing similar situations should employ a systematic approach to patient assessment. This involves 1. Understanding the underlying physiological principles of the intervention being assessed, diaphragmatic breathing. 2. Utilizing objective assessment techniques, observation of chest and abdominal movement, palpation. 3. Correlating objective findings with subjective patient reports and other vital signs. And 4. Making clinical judgments based on the totality of the evidence, always in accordance with established professional standards and guidelines, such as those provided by the NBRC. This ensures that interventions are effective and patient care is optimized. Question 12. Governance review demonstrates a patient on mechanical ventilation exhibits a significant widening of the alveolar arterial oxygen gradient, AADO2, despite a stable FiO2 and respiratory rate. The patient's mean arterial pressure is within normal limits, and lung compliance has not significantly changed. The respiratory therapist is tasked with evaluating and recommending adjustments to optimize gas exchange. Which of the following represents the most appropriate initial course of action? Option A. Assess the patient's hemodynamic status and consider interventions to improve pulmonary blood flow and ventilation distribution. Option B. Increase the positive end expiratory pressure, PEEP, by 5 cm H2O to recruit alveoli. Option C. Increase the fraction of inspired oxygen, FiO2, to 100% to ensure adequate oxygen delivery. Option D. Initiate bronchodilator therapy to reduce airway resistance and improve ventilation. The correct answer is A. Assess the patient's hemodynamic status and consider interventions to improve pulmonary blood flow and ventilation distribution. Explanation. This scenario presents a common clinical challenge where a patient's physiological response to mechanical ventilation requires careful interpretation and adjustment to optimize gas exchange. The core issue revolves around ventilation perfusion, V/Q coupling, a fundamental principle in respiratory physiology. Ensuring adequate V/Q matching is crucial for efficient oxygenation and carbon dioxide removal, and deviations can lead to hypoxemia or hypercapnia. The challenge lies in distinguishing between primary causes of V/Q mismatch and the body's compensatory mechanisms, and then intervening appropriately without causing further harm. The correct approach, which involves assessing the patient's overall clinical status and V/Q matching, represents best professional practice because it aligns with the National Board for Respiratory Care's emphasis on evidence-based practice and patient-centered care. Respiratory therapists are expected to utilize their knowledge of respiratory physiology, pathophysiology, and mechanical ventilation to interpret complex patient data. This approach prioritizes a comprehensive understanding of the patient's condition, including hemodynamic status, lung mechanics, and gas exchange, to guide therapeutic decisions. It adheres to the ethical principle of beneficence by seeking to improve patient outcomes and avoid harm. Furthermore, it reflects the professional responsibility to continuously monitor and adjust ventilator settings based on real-time patient response, a core competency for respiratory care practitioners. An incorrect approach that focuses solely on increasing the fraction of inspired oxygen, FiO2, without considering the underlying V/Q mismatch is professionally unacceptable. This is a superficial intervention that may temporarily improve oxygen saturation, but fails to address the root cause of the problem. It can lead to oxygen toxicity and may mask worsening pulmonary pathology, delaying necessary interventions. Ethically, this approach violates the principle of non-maleficence by potentially causing harm through prolonged exposure to high FiO2 and by failing to provide effective treatment. It also demonstrates a lack of professional competence in interpreting V/Q dynamics. Another incorrect approach, which involves solely increasing the positive end expiratory pressure, PEEP, without a thorough assessment, is also professionally unacceptable. While PEEP can improve oxygenation by recruiting alveoli and increasing functional residual capacity, an indiscriminate increase can lead to overdistension, reduced venous return, and increased dead space, thereby worsening V/Q mismatch. This approach fails to consider the potential negative hemodynamic consequences and the specific reasons for the V/Q imbalance. It represents a failure to apply a systematic and evidence-based decision-making process, potentially leading to patient harm and violating the principles of beneficence and non-maleficence. A professional decision-making process for similar situations should involve a systematic assessment of the patient's V/Q status. This begins with a thorough review of arterial blood gas ABG results, alongside other relevant clinical data such as chest X-rays, ventilator graphics, and hemodynamic parameters. The therapist should then consider the potential causes of V/Q mismatch, such as pulmonary embolism, atelectasis, pneumonia, or ARDS. Based on this comprehensive assessment, appropriate interventions should be selected, which might include adjusting ventilator settings, tidal volume, respiratory rate, PEEP, inspiratory time, optimizing patient positioning, administering bronchodilators or diuretics, or collaborating with the medical team for further diagnostic workup or pharmacological interventions. The key is to address the underlying physiological derangement rather than just the symptom of hypoxemia. Question 13. The performance metrics show a significant and consistent deviation from the expected patient response to a prescribed respiratory therapy, raising concerns about its efficacy or the patient's current condition. As a respiratory therapist operating under the National Board for Respiratory Care's regulatory framework, what is the most appropriate initial course of action? Option A. Adjust the dosage or frequency of the prescribed respiratory therapy based on the performance metrics without informing the physician. Option B. Conduct a comprehensive patient assessment, review the patient's chart for relevant clinical information, and consult with the supervising physician to discuss the findings and potential adjustments to the therapy. Option C. Document the performance metric deviation in the patient's chart, but continue the current therapy as prescribed, assuming the metrics may be inaccurate. Option D. Immediately discontinue the current respiratory therapy and initiate an alternative treatment based on the therapist's clinical judgment, without physician consultation. The correct answer is B. Conduct a comprehensive patient assessment, review the patient's chart for relevant clinical information, and consult with the supervising physician to discuss the findings and potential adjustments to the therapy. Explanation. Scenario analysis. This scenario is professionally challenging because it requires a respiratory therapist to balance the immediate needs of a patient with the established regulatory framework governing respiratory care. The performance metrics, while indicating a potential issue, do not automatically dictate a specific course of action without further investigation and adherence to established protocols. The therapist must exercise clinical judgment within the bounds of their professional scope and regulatory requirements. Correct approach analysis. The correct approach represents best professional practice because it prioritizes patient safety and adherence to the National Board for Respiratory Care, NBRC, established standards and guidelines. This involves a systematic process of assessment, documentation, and communication, ensuring that any deviation from standard practice is justified, understood, and approved by appropriate personnel. This aligns with the NBRC emphasis on competent and ethical practice, which includes proper patient management and continuous quality improvement. Incorrect approaches analysis. One incorrect approach involves immediately altering the prescribed therapy based solely on performance metrics without a comprehensive patient assessment or physician consultation. This bypasses established protocols for medication management and patient care, potentially leading to adverse events and violating the regulatory framework that mandates physician orders for therapeutic interventions. It demonstrates a failure to adhere to the principle of practicing within one scope and respecting the physician-patient relationship. Another incorrect approach is to ignore the performance metrics entirely, assuming they are erroneous or insignificant. This neglects the therapist's professional responsibility to monitor patient response to therapy and to identify potential problems. The NBRC expects practitioners to be proactive in patient care and to utilize available data for assessment and intervention, making this approach a failure to meet professional standards of vigilance and patient advocacy. A third incorrect approach is to document the observed deviation without taking any further action or seeking clarification. While documentation is crucial, it is insufficient on its own. The regulatory framework implies a responsibility to act upon observed clinical data that may indicate a need for intervention or adjustment of care. Failing to act on the documented information represents a lapse in professional responsibility and a potential risk to patient well-being. Professional reasoning. Professionals should approach such situations by first conducting a thorough clinical assessment of the patient to understand the context of the performance metrics. This should be followed by consulting the patient's medical record and physician's orders. If the metrics suggest a deviation from expected outcomes or a potential problem, the therapist should communicate their findings and concerns to the supervising physician or appropriate healthcare team member. Documentation of all assessments, communications, and actions taken is paramount. This systematic process ensures that patient care is evidence-based, safe, and compliant with regulatory requirements. Question 14. Process analysis reveals that a respiratory therapist is evaluating a patient's respiratory status. The therapist has obtained objective measurements of tidal volume, respiratory rate, and oxygen saturation. To accurately interpret these findings and guide subsequent care, what crucial contextual factors must the therapist consider in conjunction with the objective data? Option A. The patient's preferred television channel and room decor. Option B. The ambient temperature and humidity of the treatment room. Option C. The patient's age, gender, and current body position. Option D. The patient's recent dietary intake and medication history. The correct answer is C. The patient's age, gender, and current body position. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a respiratory therapist must interpret physiological data in the context of patient-specific factors. The challenge lies in recognizing that standard respiratory parameters can be significantly influenced by non-pathological variables such as age, gender, and body position. A failure to account for these factors can lead to misinterpretation of data, inappropriate treatment decisions, and potentially adverse patient outcomes. The professional challenge is to integrate this knowledge into the assessment process, moving beyond a purely mechanical interpretation of numbers to a nuanced understanding of the patient's unique physiological state. Correct approach analysis. The correct approach involves recognizing that a younger adult male in a supine position will likely exhibit different baseline respiratory mechanics and gas exchange compared to an older adult female in a semi-Fowler's position. Specifically, age can affect lung elasticity and respiratory muscle strength. Gender can influence thoracic cage dimensions and respiratory muscle mass. And body position dramatically impacts diaphragmatic excursion and ventilation perfusion matching. Therefore, a therapist must adjust their interpretation of objective measurements, e.g., tidal volume, respiratory rate, oxygen saturation, based on these known physiological variations. This aligns with the National Board for Respiratory Care's emphasis on patient-centered care and the application of scientific principles to individual patient needs, ensuring that assessments are accurate and treatments are tailored. Incorrect approach is analysis. One incorrect approach would be to solely rely on normative values for respiratory function without considering the patient's age, gender, or body position. This fails to acknowledge the significant physiological variability that exists and can lead to misdiagnosis or inappropriate therapeutic interventions. For instance, a slightly lower than average tidal volume in an elderly patient might be normal for them, whereas it could indicate a problem in a younger individual. This approach violates the ethical principle of providing competent care by neglecting crucial patient-specific data. Another incorrect approach would be to assume that any deviation from a textbook normal value, regardless of patient factors, necessitates immediate intervention. This can lead to overtreatment and unnecessary patient distress. For example, a slight increase in respiratory rate in an older patient who is comfortable and well oxygenated might simply be a compensatory mechanism for reduced lung compliance due to age, rather than an indicator of respiratory distress requiring immediate bronchodilator therapy. This approach demonstrates a lack of critical thinking and an inability to synthesize information, which is a core competency expected of respiratory therapists. A third incorrect approach would be to prioritize one factor e.g., age, while ignoring others e.g., body position. For example, focusing only on age-related changes in lung function, while disregarding the significant impact of a supine position on ventilation perfusion matching, would lead to an incomplete and potentially misleading assessment. This selective application of knowledge is not reflective of comprehensive patient assessment and can result in overlooking critical physiological changes. Professional reasoning. Professionals should employ a systematic decision-making framework that begins with a thorough patient assessment, incorporating demographic data, age, gender, current clinical presentation, and environmental factors, body position. This information should then be used to contextualize objective measurements. The therapist should compare findings not to absolute norms, but to expected values for that specific patient profile. If deviations are noted, the therapist must then consider potential underlying pathologies. This iterative process of assessment, contextualization, and analysis allows for accurate interpretation and the development of appropriate, individualized care plans, adhering to the professional standards and ethical obligations of respiratory care practice. Question 15. Consider a scenario where a 68-year-old male patient with a history of COPD is admitted with increased shortness of breath and wheezing. His arterial blood gas analysis reveals a pH of 7.30, PaCO2 of 55 mmHg, PaO2 of 60 mmHg, and HCO3 of 28 mx/L. He is currently receiving supplemental oxygen via nasal cannula at 2L/min and nebulized bronchodilators every 4 hours. The respiratory therapist observes that the patient remains dyspneic, with shallow respirations and audible wheezing. Which of the following actions best reflects appropriate management based on this information? Option A. Document the ABG results and continue the current oxygen therapy, as no significant change in condition is noted. Option B. Increase the FiO2 delivered via nasal cannula and continue the current bronchodilator regimen. Option C. Reassure the patient and encourage pursed lip breathing, as the ABG values are consistent with his known COPD. Option D. Administer a continuous nebulized bronchodilator treatment and consider non-invasive positive pressure ventilation. The correct answer is B. Increase the FiO2 delivered via nasal cannula and continue the current bronchodilator regimen. Explanation. This scenario presents a common clinical challenge in respiratory care. Interpreting arterial blood gas, AB, results in the context of patients' evolving clinical presentation. The difficulty lies in synthesizing multiple data points, the ABG values, the patient's symptoms, and the prescribed therapy to arrive at the most appropriate intervention. Professional judgment is required to move beyond simply identifying a single abnormal value, and instead to understand the underlying physiological derangements and their implications for patient management. The correct approach involves a comprehensive assessment of the ABG results in conjunction with the patient's clinical status and the effectiveness of current therapy. This aligns with the National Board for Respiratory Care's emphasis on evidence-based practice and patient-centered care. Best professional practice dictates that respiratory therapists must integrate all available information to make informed decisions that optimize patient outcomes. This includes recognizing that ABG values are dynamic and must be interpreted within the broader clinical picture. The regulatory framework implicitly supports this by requiring competent and ethical practice, which necessitates a holistic approach to patient assessment and management. An incorrect approach would be to solely focus on a single ABG parameter, such as the pH, without considering the other values, PaCO2, PaO2, HCO3, or the patient's clinical presentation. This could lead to inappropriate interventions. For instance, solely addressing a low pH without considering the cause, e.g., respiratory acidosis vs. metabolic acidosis, would be a failure to apply fundamental physiological principles and could exacerbate the patient's condition. Another incorrect approach would be to assume the current therapy is adequate without re-evaluating its effectiveness based on the ABG results and clinical signs. This demonstrates a lack of critical thinking and a failure to adapt care to the patient's needs, potentially violating ethical obligations to provide competent care. A further incorrect approach would be to disregard the ABG results entirely and rely solely on subjective clinical observations, which would be a failure to utilize essential diagnostic tools and could lead to misdiagnoses or delayed treatment. Professionals should employ a systematic decision-making process. First, thoroughly review the ABG results, noting all values and their deviations from normal. Second, correlate these values with the patient's signs and symptoms, considering the underlying pathophysiology. Third, evaluate the effectiveness of current therapeutic interventions in addressing the identified abnormalities. Finally, based on this integrated assessment, formulate a plan for further intervention or adjustment of therapy, always prioritizing patient safety and well-being. Question 16. The investigation demonstrates a patient undergoing polysomnography who repeatedly removes sensors and attempts to disconnect equipment, stating they are uncomfortable and do not understand the purpose of the attachments. The respiratory therapist has already attempted to reposition the sensors and briefly explained the general purpose of the study. What is the most appropriate course of action for the respiratory therapist? Option A. Immediately terminate the polysomnography study and inform the patient that they are not cooperating. Option B. Re-explain the specific purpose of each sensor and the importance of uninterrupted data collection for accurate diagnosis, and if noncompliance persists, document the patient's actions and consult with the interpreting physician regarding the study's validity. Option C. Continue the study, ignoring the patient's actions, and document all sensors as being properly attached and functioning. Option D. Attempt to physically restrain the patient to prevent further sensor removal and equipment disconnection. The correct answer is B. Re-explain the specific purpose of each sensor and the importance of uninterrupted data collection for accurate diagnosis, and if noncompliance persists, document the patient's actions and consult with the interpreting physician regarding the study's validity. Explanation. This scenario presents a professional challenge due to the inherent conflict between patient autonomy, the need for accurate diagnostic data, and the potential for misinterpretation of results when a patient is not fully compliant with study protocols. The respiratory therapist must balance the ethical imperative to respect patient wishes with the responsibility to ensure the integrity and validity of the polysomnography study, which directly impacts patient care decisions. Careful judgment is required to navigate this situation without compromising patient dignity or the scientific rigor of the study. The correct approach represents best professional practice because it prioritizes patient communication and education while seeking to uphold the integrity of the diagnostic process. By attempting to re-educate the patient and explain the importance of adherence to the protocol, the therapist respects the patient's right to understand their care. If adherence cannot be achieved, documenting the patient's noncompliance and the potential impact on data validity is crucial. This documentation ensures transparency and allows the interpreting physician to make informed decisions, acknowledging any limitations in the study's findings. This aligns with the National Board for Respiratory Care's emphasis on ethical conduct, patient advocacy, and the provision of competent respiratory care services, which includes ensuring the accuracy of diagnostic procedures. An incorrect approach that involves immediately terminating the study without further attempt at patient education or consultation with the physician fails to uphold the principle of patient advocacy. It bypasses opportunities to address the patient's concerns or misunderstandings, potentially leading to a suboptimal patient experience and a missed diagnostic opportunity. This also risks generating incomplete or unreliable data without proper contextualization for the physician. Another incorrect approach, such as forcibly restraining the patient to ensure adherence, would be a severe ethical and regulatory violation. It infringes upon patient autonomy and bodily integrity, constituting a breach of trust and potentially leading to legal ramifications. Respiratory therapists are bound by ethical codes that prohibit such actions. Finally, an incorrect approach of proceeding with the study while ignoring the patient's actions and documenting them as compliant would be a direct violation of professional integrity and honesty. This misrepresentation of data compromises the diagnostic process, potentially leading to incorrect medical management and harm to the patient. It also violates the principle of accurate record keeping, a fundamental requirement in healthcare. The professional decision-making process for similar situations should involve a systematic approach. First, assess the situation and identify the ethical and professional conflict. Second, attempt to communicate and educate the patient, addressing their concerns and explaining the rationale behind the protocol. Third, if adherence remains an issue, consult with the supervising physician to discuss the implications for the study and patient care. Fourth, meticulously document all interactions, patient noncompliance, and any decisions made, ensuring transparency and accountability. Question 17. Upon reviewing a patient's home sleep apnea therapy (CPAP) compliance data, you note a significant decrease in usage over the past month. The patient has a diagnosed moderate obstructive sleep apnea and was previously compliant. What is the most appropriate course of action for the respiratory therapist? Option A. Schedule a follow-up appointment with the patient to assess for any barriers to CPAP use, provide further education, and collaboratively explore potential adjustments to the therapy. Option B. Advise the patient that continued noncompliance will result in the termination of respiratory therapy services for their sleep apnea. Option C. Immediately contact the physician to request an increase in the CPAP pressure settings, assuming the current pressure is no longer effective. Option D. Document the decreased compliance in the patient's chart and recommend that the physician consider discontinuing the CPAP therapy due to non-adherence. The correct answer is A. Schedule a follow-up appointment with the patient to assess for any barriers to CPAP use, provide further education, and collaboratively explore potential adjustments to the therapy. Explanation. Scenario analysis. This scenario presents a common challenge in respiratory care. Managing a patient with a diagnosed sleep-related breathing disorder or adherence to prescribed therapy is suboptimal. The professional challenge lies in balancing the patient's autonomy and preferences with the clinician's responsibility to ensure effective treatment and patient safety, as mandated by NBRC guidelines and ethical practice. The clinician must navigate potential barriers to adherence while respecting the patient's right to make informed decisions about their care. Correct approach analysis. The correct approach involves a comprehensive, patient-centered strategy that addresses the underlying reasons for non-adherence. This aligns with NBRC emphasis on patient education, assessment, and individualized care plans. By conducting a thorough assessment to identify barriers, providing targeted education, and collaboratively developing a revised treatment plan, the respiratory therapist upholds their professional responsibility to optimize patient outcomes and promote adherence to evidence-based therapies for sleep-related breathing disorders. This approach respects patient autonomy while ensuring the delivery of quality care. Incorrect approaches analysis. One incorrect approach is to simply document non-adherence and cease further intervention without attempting to understand or address the issue. This fails to meet the NBRC expectation of proactive patient management and can lead to worsening of the sleep-related breathing disorder, impacting the patient's health and quality of life. Ethically, it represents a failure to provide appropriate care. Another incorrect approach is to unilaterally increase the prescribed therapy pressure without patient consultation or further assessment. This disregards the patient's experience and potential discomfort, which can further decrease adherence and may not be clinically indicated without a proper evaluation of the current settings and their effectiveness. This violates principles of informed consent and patient-centered care. A third incorrect approach is to dismiss the patient's concerns about the therapy as simply being difficult or uncooperative. This judgmental attitude prevents effective problem-solving and damages the therapeutic relationship. It is unprofessional and counterproductive to achieving treatment goals for sleep-related breathing disorders. Professional reasoning. When faced with patient non-adherence to therapy for sleep-related breathing disorders, respiratory therapists should employ a systematic decision-making process. This begins with a non-judgmental assessment to identify specific barriers to adherence, such as mask discomfort, air leaks, claustrophobia, or perceived lack of benefit. Following this, patient education should be reinforced, tailored to their understanding and concerns. Collaborative problem-solving with the patient is crucial to modify the treatment plan, which may involve adjusting equipment, settings, or exploring alternative therapies, always within the scope of practice and physician orders. Documentation of all assessments, interventions, and patient responses is essential for continuity of care and regulatory compliance. Question 18. System analysis indicates a patient receiving mechanical ventilation for acute respiratory distress syndrome, ARDS, has shown a gradual increase in their respiratory rate from 18 to 24 breaths per minute over the past 2 hours, accompanied by a subjective report of increased shortness of breath. Their oxygen saturation remains stable at 94% on the current ventilator settings. What is the most appropriate initial approach for the respiratory therapist? Option A. Administer a prescribed dose of a short-acting bronchodilator via the ventilator circuit to address potential bronchospasm contributing to the dyspnea. Option B. Document the patient's increased respiratory rate and subjective dyspnea in the medical record and continue current ventilator settings, awaiting the next scheduled assessment. Option C. Perform a comprehensive respiratory assessment, including auscultation, palpation, percussion, review of ventilator graphics and alarms, and examination of recent laboratory results to identify potential causes for the increased work of breathing. Option D. Immediately increase the fraction of inspired oxygen, FiO2 to 0.60 to address the patient's reported shortness of breath and ensure adequate oxygenation. The correct answer is C. Perform a comprehensive respiratory assessment, including auscultation, palpation, percussion, review of ventilator graphics and alarms, and examination of recent laboratory results to identify potential causes for the increased work of breathing. Explanation. This scenario presents a common challenge in respiratory care, interpreting subtle changes in a patient's condition and determining the most appropriate intervention based on comprehensive assessment. The professional challenge lies in distinguishing between normal physiological variations and early signs of deterioration, which requires a deep understanding of patient history, current clinical presentation, and the potential impact of various interventions. Careful judgment is paramount to avoid unnecessary treatments that could cause harm or delay critical interventions that could improve outcomes. Correct approach represents best professional practice because it prioritizes a systematic and thorough patient assessment before initiating any intervention. This aligns with the National Board for Respiratory Care's emphasis on evidence-based practice and patient safety. A comprehensive assessment, including reviewing the patient's history, current vital signs, physical examination findings, and recent laboratory data, provides a holistic view of the patient's status. This allows for the identification of the root cause of the observed changes, leading to a targeted and effective treatment plan. This approach is ethically sound, as it upholds the principle of beneficence by acting in the patient's best interest and non-maleficence by avoiding potentially harmful interventions. It also adheres to professional standards of care that mandate a thorough evaluation before treatment. An incorrect approach that involves immediately increasing oxygen therapy without a complete assessment fails to address the underlying cause of the patient's symptoms. This could mask a more serious issue, such as a pneumothorax or pulmonary embolism, leading to delayed diagnosis and treatment. Ethically, this approach violates the principle of non-maleficence by potentially causing harm through inappropriate intervention and beneficence by not acting in the patient's best interest. It also deviates from professional standards that require a diagnostic approach. Another incorrect approach, focusing solely on the patient's subjective report of dyspnea without objective data, is insufficient. While patient perception is important, it must be correlated with objective findings. Relying solely on subjective data can lead to misdiagnosis and inappropriate treatment, potentially missing critical objective signs of distress. This approach is ethically problematic as it may not fully address the patient's physiological needs and could lead to suboptimal care. Finally, an approach that involves documenting the changes but delaying further action until the next scheduled assessment overlooks the dynamic nature of respiratory conditions. Respiratory distress can rapidly escalate, and delaying intervention can have severe consequences. This approach is ethically deficient as it fails to act with due diligence and can be considered a breach of the standard of care, potentially leading to patient harm. Professionals should employ a decision-making framework that begins with recognizing a change in the patient's status. This should trigger a systematic assessment process, starting with a review of the patient's baseline and recent history. Objective data, vital signs, physical exam, labs should be gathered and correlated with subjective reports. Based on this comprehensive assessment, potential causes are identified, and the most likely diagnosis is formulated. Treatment options are then considered, prioritizing those that are evidence-based, address the identified cause, and minimize risk. Continuous monitoring and reassessment are crucial to evaluate the effectiveness of interventions and adjust the plan as needed. Question 19. Examination of the data shows a patient presenting with persistent hemoptysis and a suspected endobronchial lesion. The patient has a history of smoking and mild cough. The physician has requested a bronchoscopy for diagnosis and potential intervention. Considering the patient's condition and the need for tissue sampling, which of the following approaches best aligns with current respiratory care practice guidelines for initial diagnostic bronchoscopy in this scenario? Option A. Flexible bronchoscopy with forceps biopsy of the endobronchial lesion. Option B. Flexible bronchoscopy with bronchoalveolar lavage bowel and bronchial washings only, deferring tissue biopsy. Option C. Flexible bronchoscopy with endobronchial ultrasound (EBUS) for real-time visualization and transbronchial needle aspiration (TBNA) of any suspicious lesions. Option D. Rigid bronchoscopy with direct visualization and biopsy of the endobronchial lesion. The correct answer is C. Flexible bronchoscopy with endobronchial ultrasound (EBUS) for real-time visualization and transbronchial needle aspiration (TBNA) of any suspicious lesions. Explanation: this scenario presents a common clinical challenge where a patient's condition necessitates a diagnostic procedure, but the choice of technique requires careful consideration of patient factors and potential risks. The professional challenge lies in balancing the need for definitive diagnosis with patient safety and the efficient use of resources, all within the scope of respiratory care practice as defined by the National Board for Respiratory Care, NBRC. The correct approach represents best professional practice because it aligns with established NBRC guidelines and ethical principles of patient care. It prioritizes a less invasive diagnostic method that can provide sufficient information for initial management, thereby minimizing patient risk and discomfort. This approach demonstrates adherence to the principle of do no harm and the judicious application of clinical judgment. An incorrect approach that involves immediately proceeding with a more invasive procedure without fully exploring less invasive options fails to adhere to the principle of least harm. It could lead to unnecessary patient risk, complications, and increased healthcare costs. Ethically, it may be considered a failure to adequately assess the patient's needs and to provide care that is both effective and appropriate. Another incorrect approach, such as delaying the procedure due to perceived complexity, could result in delayed diagnosis and treatment, potentially worsening the patient's condition and violating the duty of timely care. Professionals should employ a systematic decision-making process that begins with a thorough assessment of the patient's clinical presentation, history, and current status. This assessment should then inform the selection of the most appropriate diagnostic or therapeutic intervention, considering the indications, contraindications, risks, and benefits of each available technique. Consultation with other healthcare professionals, adherence to institutional protocols, and continuous evaluation of the patient's response are also crucial components of sound professional reasoning. Question 20. Performance analysis shows a patient admitted with pneumonia has a sputum culture that identifies Streptococcus pneumoniae, sensitive to penicillin but resistant to azithromycin. The patient is currently receiving azithromycin. What is the most appropriate next step for the respiratory therapist to recommend to the physician? Option A. Continue azithromycin as the patient is showing some clinical improvement. Option B. Recommend a change in antibiotic therapy to penicillin, given the sensitivity results. Option C. Recommend a repeat sputum culture to confirm the initial findings. Option D. Recommend a broad-spectrum antibiotic that covers both penicillin-sensitive and azithromycin-resistant organisms. Correct answer is B. Recommend a change in antibiotic therapy to penicillin, given the sensitivity results. Explanation: scenario analysis. This scenario presents a common clinical challenge where a respiratory therapist must interpret laboratory results to guide patient care. The challenge lies in understanding the implications of sputum analysis and culture findings in the context of a patient's clinical presentation and the potential for antibiotic resistance. Misinterpretation can lead to inappropriate treatment, delayed recovery, and increased risk of complications. Correct approach analysis. The correct approach involves correlating the sputum culture and sensitivity results with the patient's signs and symptoms, as well as the prescribed antibiotic regimen. This ensures that the chosen antibiotic is effective against the identified pathogen and at an appropriate dosage. This aligns with the National Board for Respiratory Care's emphasis on evidence-based practice and patient safety, which implicitly requires the therapist to utilize all available diagnostic information to optimize therapeutic outcomes. Adherence to established clinical guidelines for managing respiratory infections, which often incorporate interpretation of culture data, is also paramount. Incorrect approach is analysis. One incorrect approach would be to solely rely on the presence of a specific organism in the sputum culture without considering its sensitivity to the prescribed antibiotic. This could lead to continuing an ineffective antibiotic, prolonging the patient's illness and potentially contributing to the development of further resistance. This fails to meet the standard of care expected by the NBRC, which prioritizes effective and evidence-based treatment. Another incorrect approach would be to disregard the sputum culture results entirely and continue the current antibiotic based on clinical improvement alone, especially if the improvement is marginal or if the initial choice of antibiotic was empirical. This ignores crucial diagnostic data that could guide more targeted and effective therapy, potentially leading to treatment failure or the selection of an inappropriate broad-spectrum antibiotic when a narrower, more effective agent is indicated. This demonstrates a failure to integrate diagnostic information into clinical decision-making, a core competency assessed by the NBRC. A third incorrect approach would be to immediately switch to a different broad-spectrum antibiotic without a clear rationale or further investigation, simply because the initial culture showed a pathogen. This can lead to unnecessary antibiotic exposure, increased risk of side effects, and the promotion of multi-drug-resistant organisms. It bypasses the critical step of evaluating the sensitivity of the identified pathogen to existing or alternative agents. This represents a departure from judicious antibiotic stewardship and evidence-based practice. Professional reasoning. Respiratory therapists should employ a systematic decision-making process when interpreting sputum analysis and culture results. This involves 1. Reviewing the patient's current clinical status, including symptoms, vital signs, and radiographic findings. 2. Carefully examining the sputum culture report, noting the identified organism, S, and their corresponding antibiotic sensitivities. 3. Comparing the sensitivity profile with the currently prescribed antibiotic regimen. 4. Consulting with the physician or infectious disease specialist if there is a discrepancy or uncertainty regarding the optimal therapeutic strategy. 5. Considering the patient's history of allergies and previous antibiotic responses. This integrated approach ensures that diagnostic data directly informs and optimizes patient care, aligning with professional responsibilities and regulatory expectations.